them because we have gone through that. So the weight bearing, the radiological views, we know how to do that. Anteroposterior inlet and outlet views, which are very critical, and of course the CT scan, all those things. We're going to skip that, and classification also. So resuscitation wise, anteroposterior compression injury is the most prone for hemodynamic instability. We have to understand that whenever we diagnose an anteroposterior compression injury, we have to look forward for, so the injuries that can cause problems are, one is the LC3 injuries, APC2 and APC3 injuries, and vertical shear and combined mechanism injuries. These are prone for hemodynamic instability and needs resuscitation. As Dr. Ajit was mentioning, we need external fixator, pelvic packing, infix, all those things. And we see that as many as, on a ratio, when we compare, APC3 injury is the one that has the highest resuscitation requirement, hemodynamic instability. So the most important part of an APC injury is fixation to avoid hemodynamic instability in death, preventing the patient from bleeding to death. So the anteroposterior compression injury, as we see, the force is from the front and the pelvis opens up. So when it opens up, it gradually opens up as the force increases. So an APC1 injury is just pubic diastasis. The pubic diastasis up to 2.5 centimeters has been found that still the sacral tuberous and the sacrospinous ligaments are intact. They are not injured. And beyond 2.5 centimeters, as the amount of gap in the pubic symphysis increases, it has been found that gradually the sacrospinous and the sacrotuberous ligaments get torn, then the anterior sacroiliac joint ligaments, the interosseous sacroiliac joint ligaments gets torn, and finally the posterior sacroiliac ligament gets torn. So that is the severity of the injury, and that's how it has been graded also. And APC1 is a stable injury with anterior ligament injury. APC2, the sacrospinous ligament is torn and the anterior sacroiliac injury is there, and possibly the sacrotuberous is also torn, but the posterior sacroiliac is intact. And third one, wherein it's completely torn. So we'll see some examples. As that we see the force is from here and it opens up, the pelvis opens up, and that's when you get major hemodynamic instability. The iliac veins here in this region can get injured. So that's the evaluation. So as we see here, CT scan actually elucidates this beautifully. We see that the sacroiliac joint is opening up, but posteriorly it is still intact, as we see here. So an APC1 injury is the diastasis of the pubis, but these ligaments are intact, and mild opening up, but these ligaments are also fine, as we see here. And then, as I was mentioning, the ligaments will be intact, so it's a stable fracture. We don't need to do any surgery. We can treat it conservatively. We just have to use a pelvic binder, and if the patient has severe pain, maybe we can use an external fixator or an infix. That's just enough to manage these injuries, and of course rest. Next is the APC2 injuries, wherein gradually the diastasis becomes more, these ligaments start tearing off, and then the ligaments of the anterior sacroiliac joint and the interosseous ligaments start tearing off. That is when the posterior part is unstable. So as I was mentioning, the weight bearing happens from the femoral head through the sciatic buttress onto the sacrum. So this line is broken. So when this line is broken, we have to fix it. The idea is we have to protect this, otherwise they will have pain. So as we see, sacrospinous and sacrotuberous ligaments are gone, and the pelvic floor ligaments are violated, and sacroiliac ligaments are also gone. Some of the examples, as we see here, pubic diastasis and anterior opening of the sacroiliac joint. Here again, same thing here. Can you see the opening up and opening up the sacroiliac joint here? So we also have to see some telltale signs. Sometimes there is avulsion of the sacral bone, as we see here. It can avulse from here. This is a telltale. It will tell about the possibility of severity of the injury. It actually is a sacrospinous ligament taking away a piece of the sacrum. That can happen. So anterosacroiliac ligaments are disrupted. Okay, and APC3 is complete iliosacral dissociation. That means to say the whole hemipelvis is separate. There is no connection. The posterosacral ligaments are also gone, and it is very, very unstable. As we see here, there is a huge gap here between the sacrum and the ilium. Similarly here, can you see that? It's a huge gap. So APC3 injuries, they are very severe injuries which needs to be fixed. First thing is the pelvic binder, the external fixator followed by internal fixation. So basically in management wise, an APC1 injury, conservative treatment, APC2 injuries, anterior stabilization. It's like closing a book. We complete the ring and automatically the posterior part, since the posterior ligaments are intact, once we close the book, even if the anterosacral ligaments are gone, they actually can hold the posterior components in place and we can fix it. But of course, an anterior fixation is not as stronger as a posterior sacroiliac joint fixation. And in APC3 injuries, we need to do anterior and posterior stabilization. So as I was mentioning, up to 2.5 centimeters, there is not much of a problem. As it becomes, but that number is not absolute, because what happens is it opens up and it comes back. So we don't know. Actually, it may be looking like only 2.5 centimeters, but in reality, it has opened up much wider, broken the ligaments and come back. And when we have put a pelvic binder, it has come back. So we have to take care of that. So it's always not a static picture, but the dynamic picture we should be worried about. And that's the same actually compared to the, and as I was mentioning, we should always look for, before surgical, as Dr. Magoo was mentioning, for open injuries, moral lavalier lesions, these should be taken care of, and multidisciplinary approach is required, and it's easy to reduce within first 24 to 48 hours. After that, we have to give them time. The interleukins will raise, and we usually used to do interleukin 6 levels to see the severity of the injury, and then external fixator, and the approach is of course similar. Okay, so anterior fixation is by Fenner-Steele approach. We have talked about it. And how do we reduce it? We can use a simple Weber's clamp and slide it onto the superior part of the obturator foramen and approach it and put a plate on top. Or we can use the Youngblood clamps to put 2 screws and we approximate it. And this actually slides also. So we can approximate it. These are the 2 ways of approximating it. And of course we put a plate. A 6-hole plate is used to close the anterior part. Second one is for posterior. APC2 injuries, we use sacroiliac plates in the anterior part. It's just a bone graft incision. We go, here there will be a nutrient foramina which bleeds a lot. We got to pack it with bone bags. And only 1 screw can be passed on the sacrum. And we can actually put 2 screws onto this side, but only 1 screw on the sacrum, because there's the L5 nerve root very close by. And usually, this is just a schematic diagram, but usually between the 2 plates, there should be about 70 degrees of angulation. And these screws usually hold the sciatic buttress, and these screws usually hold the iliac crest. And of course, posterior approach can be done, but it's good for a crescent fracture, but not good enough for a simple sacroiliac disruption. Okay, so that's the anterior exposure showing the fixation. How do we maneuver? We can actually put in a clamp on the iliac crest and maneuver, or we can use a lever to get it back in place, and that's a fixation. Actually, we have used a single plate and a iliosacral screw here, or we can use span a iliosacral screw across. Iliosacral screw across.